Good morning, everyone. My name is Maddie and today I'll be presenting a clinical case that demonstrates the impact of systemic infection, bowel dysfunction, and malabsorption on a patient's nutritional needs. A 32-year-old female presented to the hospital experiencing persistent headaches, diarrhea, fever, night sweats, general malaise, and a rash on her legs. Additionally, over the past 3 months, she had experienced abdominal distension, a poor appetite, nausea, epigastric pain, and vomiting. Shortly after admission, she developed pulmonary edema and hypotension. She had abdominal scans done as well as labs, and the abnormal labs are listed on the slides. The image on the left shows the lungs of an individual with hantavirus, with visible white patches indicating fluid in the lungs. The abdominal scans revealed distension of the stomach and the small intestines, and the presence of a tube-like structure moving independently from the regular peristalsis movement. As you can see, the image on the right shows multiple dilated loops of bowel, which is characteristic of small bowel obstruction, and on the left you will see the ascariasis roundworm that was stuck in the intestines, and most likely this worm got stuck due to the high inflammation in this area already because this patient had Crohn's disease. The symptoms, labs, and imagings were consistent with the primary and secondary diagnosis of hantavirus pulmonary syndrome, valley fever, small bowel obstruction secondary to ascariasis, and severe protein-calorie malnutrition. The patient's relevant medical history includes Crohn's disease, vitamin deficiencies, acute pancreatitis, and a terminal ileal resection secondary to Crohn's disease. Crohn's disease is an inflammatory disease of the small intestines that leads to damage of the intestinal walls, including the villi and microvilli. Damage to the walls impacts absorption of calories from proteins, vitamins, and fats. Crohn's disease leads to deficiencies in many of these nutrients. The patient has deficiencies of vitamin B12 and vitamin D, most likely related to the pathophysiology of Crohn's disease. Both of these vitamins are absorbed in the small intestines. Further nutrition and supplemental measures are taken in cases like these to ensure that these vitamins are at sufficient levels, since they are vital for red blood cell formation and bone metabolism. In this patient's case, through lab work, she showed low hemoglobin, hematocrit, red blood cell count, and platelet count levels, as could be predicted in someone with Crohn's disease. The patient has also undergone a terminal ileal resection, which exacerbates the previously mentioned effects. Also, she reported weight loss over the past 3 months, which is common with this kind of surgery. In the patient's medical history is acute pancreatitis, which impacts the secretion of digestive enzymes, meaning that food will not be fully digested and thus not able to be properly absorbed. Long-term impacts of acute pancreatitis include malabsorption and a reduction in digestive enzyme production. Without adequate production of these from the pancreas, fat digestion and fat-soluble vitamin digestion is impeded. The patient's primary diagnosis was hantavirus pulmonary syndrome, valley fever, small bowel obstruction secondary to ascariasis. Hantavirus affects the pulmonary system with early symptoms including fever, fatigue, and muscle ache, with worsened symptoms such as diarrhea, vomiting, nausea, and abdominal pain. These symptoms are like symptoms the patient was experiencing prior to admission to the hospital. Valley fever affects the pulmonary system as well, and it is caused by breathing in spores from a fungus. Valley fever presents as a cough, fever, night sweats, rash, and shortness of breath. It is treated with antifungal medication. The previous 2 diagnoses are most in line with why the patient initially came into the hospital. The other primary diagnosis was mechanical small bowel obstruction. Mechanical small bowel obstruction is characterized by a physical barrier blocking the normal flow of intestinal contents in the lumen. Severe cases, like this patient, show necrosis and compromised blood flow and perforation of the intestinal wall. In this case, the physical barrier was the roundworm ascariasis. The secondary diagnosis was severe protein-calorie malnutrition. Protein absorption occurs mainly in the duodenum and proximal jejunum. The patient most likely experienced severe protein-calorie malnutrition because of necrosis in these areas of the intestines, as well as after the surgical resections. After looking at this clinical case, the PES statement I came up with was severe protein energy malnutrition related to protein malabsorption, secondary to duodenal and proximal jejunal resections, as evidenced by serum albumin levels of 1.8 milligrams per deciliter, a hemoglobin of 10.9 grams per deciliter, and a hematocrit of 34.3%. I calculated the nutritional needs of this patient as shown on the slides, and for the calorie needs I used the Aspen calculation, and to determine the protein and fluid amounts, I used the Nutrition Assessment Pocket Guide. Considering the different enteral nutrition formulas, I decided to select the Vital Peptide 1.5 Cal because it is a peptide-based formula for malabsorption, impaired GI function, or GI intolerance. The broken down protein will make it easier for the patient to digest, ensuring that she meets her protein and nutrient needs due to her protein malnutrition. The formula also contains vitamins B12 and vitamin D, which she has a history of deficiency in. The formula partially adheres to her desire to have a vegan diet and contains the least amount of animal products compared to the other Vital formulas, while still keeping protein at the proper amount. The tube feeding method will be a continuous feeding with flushes 3 times a day. The total formula volume will be 1,185 milliliters per day. The protein, calorie, and fluid needs will be met with this formula, and the comparison is shown on the screen. The protein needs are just on the border and may need to be adjusted up to a formula volume of 1,422 milliliters per day if the patient is tolerant on the current formula amounts. Considering surgical history and medical history, I would emphasize small, frequent meals around 5 to 6 per day, emphasizing high amounts of protein along with medium-chain triglycerides, which are fats that are more easily absorbed and oxidized. To address vitamin deficiencies, I would recommend adequate time outside for vitamin D, as well as intaking foods with vitamin D and B12, along with supplements. I would urge the patient to meet her daily fluid goals of around 1.6 liters per day to prevent dehydration. This case emphasizes the need for careful assessment and ongoing adjustment of nutrition support in patients with malabsorption, while highlighting the vital role of integrating medical history, surgical changes, and current status to develop an effective nutrition care plan.